You're watching Cablevision, Channel 14, Local Origination Programming, your hometown network.
Well, welcome to Mind Over Matter. And it's a pleasure to welcome Barbara Flory, who is the president and apparently recently re-elected last night, president of the Massachusetts Alliance for the Mentally Ill. And today we're going to talk, among other things, about when community treatment fails. So I thought perhaps to illustrate community treatment and its failures, you might tell us a little bit about how you personally got started as an advocate.
Thank you, Dr. Sigel, for having me on the program today. I appreciate the opportunity to inform you as well as the viewers about my experiences and how I think we can go forward as a group to enhance the mental health services in the state of Massachusetts. About 15 years ago, we had 4 children. Our youngest son, at the age of about 14 to 15, started acting out in school, and it was brought to our attention, but at that time, the psychologist in the school system said, well, it's just the teenage years. And he became increasingly upset, disconnected, hearing voices. He was a dreamer, and we know now it was hearing voices. We eventually sent him to a private school, and they told us that he could no longer be there because he was not behaving in a manner in which they felt was acceptable. We took him to a psychiatrist about a year and a half after he started the real subjective symptoms. Now,
and he's about how old at this point?
He was about 16 at that age, at that time. He saw him for half an hour, and he brought us into the room, his father and I, and he said, your son has schizophrenia. And this was like a bolt of lightning because I am a nurse, and I didn't have any experience personally with schizophrenia. There is none in my family that I know of. However, we knew the legacy of schizophrenia. We knew that we were really in for a long, tough struggle. So for the next 6.5 years, our son went through the devastation of mental illness, the voices, the acting out. At that time, the medications, I had many, many more side effects than some of the medications today. We just had a really, really rough time. He was placed in different settings. He fortunately was in the Solstice program, which is up in Raleigh, which that was very difficult to access from, but we sort of took it as our mission to really try and find services that would be appropriate for him, and we just took it one day at a time.
And that wasn't an easy journey, I take it.
That was a day-to-day process. It was very, very difficult.
And the difficulty accessing services, could you define that?
At that time, the service system was all right, but that the housing was a problem, and that we would get him into, they would place him into a very appropriate setting. He would just become acclimated to what we felt, he was rather stable, and we felt the setting was pretty, really decent, and then they would close the house, and this was when he was an adolescent, so adolescents do have a very difficult time anyway, and losing his friends who were mentally ill but who he really felt very strongly akin to and connected to was very devastating for him. And he eventually started to work for my husband, little jobs, filing, doing things that were within his scope of being able to participate. Then he moved into an apartment with another young man. We found the apartment. We felt that he wanted his freedom. We should allow him that liberty with a lot of support from us. And at that time, we were living in Marblehead, and he was living in Salem, so we were right in the next town, and we talked every day, and he saw us pretty much every day. The day that he committed suicide, it was very, very, really, it was just out of the blue. He had been working for his father. He took a day off. I spent the day with him. We went shopping for the cool clothes that he wanted. He went to see his therapist. He called us at 7 o'clock at night, and he asked his father for his check for the next day because he said he had seen some clothes that he felt he wanted to buy, and he hung himself at 10 o'clock in his apartment. His roommate found him, yeah. And there was no indication that day that he was unstable, that he was hallucinating, that he was felt fragmented in any way. It was no different than any other day. In fact, we felt, which I think I have learned since is kind of a sign from different other people, that when people start feeling better, that's a signal sometimes that they will have the courage, if they have suicidal ideology, to really,
act on it.
Act on it. A number of changes took place in his life and in our lives the year before that, which I think maybe played into this. Two of his siblings got married. I think he saw people moving on. He knew that he wasn't going to move on. His grandmother died, who he was very close to, 2 weeks before.
Your mother?
His father's mother.
Father's
2
mother,
weeks before he committed suicide. I think he felt he was going to a better place. He left a note. He said that we shouldn't be sad, that it was his decision. And he touched a lot of lives, and I think he showed a lot of courage. And even though I didn't agree with his final decision, I felt that that was his decision. And that took me a long time, a lot of grieving and going through that whole process to understand that even though it was not the thing that I wanted him to do, and it was absolutely, totally devastating to our whole family. I mean, we'll never be the same. However, it was something that I don't think he wanted to face life with a mental illness, and he gave up hope. And I feel the hopelessness finally got, the better of him.
Now, do you feel, because I want to get to your advocacy, but where do you think the system, looking back, could have done differently, might have done differently? Do you think in some ways the system failed, the community system?
I think the system failed in that they did close they didn't have appropriate housing. I feel much more strongly about it now because I think the system, this was in 1987, and I feel that the system has really slipped since that time. The children's system is totally inadequate. The adolescent system, while he was a part of it, I felt was not as horrible, but as it is now. However, I spent sometimes 40 hours a week on the phone trying to get services from him. So I just, somebody said no and they closed the door on me, I would just ask them who else I could call. So it was just I didn't work. It was just I was just mesmerized by the fact that I was going to have to get services from. They were going to have to be timely and appropriate, and do the best for them. The medications were deadly on them with the side effects.
And you talked about some of these houses closed. What was that all about?
It was for funding purposes. I think that they just felt that they could slash and cut in certain areas, and
They being
the Department of Mental Health, and they were Department of Mental Health facilities. So it was a very horrific time for us. It was a time that I would not wish anyone to go through. It was terrible, and it still is. It just sort of goes on and on. And you want me to talk about the Alliance? Do you want to do that at the
Well, I just want to, because we're going to have to take a break in just a couple of minutes. The closure of the house, I mean, is it your experience that sometimes perhaps the Department of Mental Health loses the long-term perspective, and that, like your son, once they settle into a place, they need to stay in that place for a long time, and it may not be just a short-term?
Well, I feel very, very strongly that people should have a home for life who are mentally ill, if that is appropriate. I feel that they put people, they place people in settings, they expect them to graduate, and some people cannot graduate into an apartment without any supports. And that is absolutely horrific in terms of people, the recidivism. I mean, people decompensate because they do not have the supports of their peers, of people who are on site. So I feel very, very strongly that the whole new initiative of taking people and just sort of moving them along, whether they're ready or not, is just totally inappropriate, and it's unconscionable.
Well, it seems like the reward for doing well is to lose the supports that have enabled you to do well, so that the moving people along really does come at a point when they need the very supports to maintain themselves.
Right. And I think that when we think of the care system, it has to be the total care system. It has to be that people are cared for medically, and this is certainly if people have adequate housing, the medical component and case management. The medical component is taken care of. It's just not the head up that we must take care of. It's the whole person. And I think that when people are in housing, there is a tendency that they are evaluated much more closely than if they're out in apartments with nothing to do all day except to sleep. It's abhorrent. It really is.
So in retrospect, I mean, independent living as compared to, say, the community supports of a halfway house, community residence, they don't compare for many people.
No, well, I think, you take your 20% of the people who are seriously or severely mentally ill and who need these services. You cannot take these services away because they do need them. And as I said, I think many of them will need them for life. No matter what kind of medication they need, that's part of their illness. It's a thought disorder.
Well, maybe after the break we could talk a little bit about the mission of the Alliance for the Mentally Ill and how you hope to accomplish an objective that might allow, say, for longevity of care. So in a second we'll pick up.
Disaster strikes and you want to help. But what happens when the tragedy is being played out on a smaller stage out of sight of reporters and television cameras? How do you know you are needed? Hello, I'm Angela Lansbury for ChildReach. In many of the world's poorest countries, poverty devastates lives with no less intensity than a hurricane or a civil war, especially the lives of children. ChildReach, one of the world's largest and most experienced sponsorship organizations, creates a continuing connection between a sponsor and a needy child overseas. This leads not only to a caring relationship, but also to family and community-based self-help programs designed to bring clean water, education, health clinics, and most of all, hope to the sponsored child and his or her family. To find out more about ChildReach, please call 800-603-1600. I'd be so grateful.
What you see here is not a man who's disabled, but a man who's simply dad. Give the power to overcome. Give to Easter Seals.
What's it like to be 7 and hear your doctor say the word cancer? Out of the darkness comes something beautiful, a wish come true, bringing hope and laughter, and a reason to keep fighting a very grown-up battle. What's it like to help? Just call us at Make-A-Wish Foundation, because there's nothing like the power of a wish.
So you're a nurse, you're president of the Alliance, you're a mother, you're an advocate.
And I'm a grandmother.
And you're a grandmother, one would never guess. But how does that bring you to the Alliance for the Mentally Ill, and what is the mission of the Alliance for the Mentally Ill, and how can it help us all kind of put in place some of the services that people like your son and many others need?
Well, I happen to feel very strongly that when my son was ill, and I discovered that the Alliance was there, which was about 6 months before his death, that they really almost saved my life in terms of really defining that their mission is a connection with you and them, and you just feel, they form a circle around you, is what they do, and they hold hands. You walk into a NAMI support meeting, and you feel that you can expose your soul to people. And you cannot do that when you're out in the public. You have to, there's certain ways that you have to act, and you cannot share some of the experiences that you've had. Whereas when I joined this group, and my son did pass on, or even if he didn't, they understand because they are family members who have had that experience. And it's a very negative experience, but we all have gained something from it. I feel that the most important mission that we have is advocacy. And the caring and sharing meetings, I think, are very, very important. For instance, we have, in Massachusetts, we have approximately about 2,000 members. We have 38 affiliates throughout the state. When someone calls our main office, which is in Waltham, we connect them with an affiliate in their area. There's something very comforting about that because, first of all, you are able to get connected to the service in your area. You are able to, it's a tremendous information sharing resource, and the people there really take you on almost as in a buddy system, so that you can call them with any concerns that you may have, or if things do not go well, they know someone who can at least assist you in helping to make it better. So for me, it has been incredibly satisfying, and I know that most of our other members feel the same way.
Well, let me ask you a question, though. A colleague recently observed that younger families aren't necessarily turning to the Alliance. Is that so? Is that your experience? And if it's partly so, is there some initiative to try to encourage younger families to participate?
A couple of weeks ago, we had our annual convention, and in my speech, one of the things that we plan on doing next year in a very active way is connecting with Parents Advocacy League, which is a children's advocacy group, and they also gave a workshop at our convention. We feel a tremendous need to connect with them so that when the kids reach the age to go out of the adolescent system and to join the adult system, that there is not a disconnect.
Okay.
And we're really working hard. We feel also we would like to do a lot of education in the school systems. We were talking about that last night at our board meeting, how we can go forward. We're going to have an educational committee. We want to attract younger people because this is what we need to do, and it's important for our mission as well as for people, because the adult system is very different than the child system, and in many, many ways.
So. What you're suggesting by identifying some of the families who have kids caught up in the children's programs, you might be able to provide them support as their kids get older.
As their kids get older. And I think that's the way we will attract younger people into the National Alliance for the Mentally Ill, because it's very necessary that people have services at all ages.
Well, you know, this show is actually sponsored by the Norfolk Alliance.
Yes.
And they're very proud of it. And at the same time, I do a lot of work in South Boston. There isn't a chapter in South Boston.
I know there isn't.
And I certainly would like to talk with you at some point later on about how to promote, because I think there's a need for that. There are a lot
There's
of...
a definite need for some services, some advocacy groups, NAMI groups in Metro Boston. We just need someone to be able to sort of take hold of the different areas, maybe, or if we could go out. We just need really some help in this, because traditionally we have not been strong in Metro Boston. We have a new Spanish-speaking affiliate in Boston, but we really need some assistance in that area. And
Okay. So now into advocacy. What is the agenda of the Alliance? And you know, you did comment that you've seen the systems get worse, really, in the last 15 or 16 years. What does the Alliance plan to do about it? What are some of the initiatives, priorities that the Massachusetts Alliance has?
Well, we have a very strong legislative priority in which we have introduced many bills. I've testified personally this year, and I think 6 or 7 bills. The parity bill, which is a good first step to having equal care for mentally ill family members. It's not the total answer. It does not cover all the populations who are served, like the Medicaid people or the ERISA people. So there are big holes, but it's a statement against stigma, and it's a recognition of the fact, I think, that mental illness is a biologically based brain disease. That's number one. We're working on the involuntary commitment bill, by which we would hope that people would take their medication. If they weren't, then they would have a conditional release, so that if they did, so that they could, if they didn't take their medication, then they would probably be reevaluated. And again, I don't know how far these. I think the parity bill, I feel very strongly the parity bill is going to fly this year, as I say. I think it's a done deal. Some of the other bills, I don't think they're really going anywhere. We certainly are very strong on managed care, constraints on managed care. And there's just there's a lot of, the legislative initiative is very, very much in our forefront right now.
Well, let's dwell on that for a moment for the remainder of this segment. Parity, does that worry you? Aspects of it. You know, my concern is that one day we'll wake up and we will have achieved it and we won't like it, because it's so highly medical model, medically necessary treatments, and a lot of the services that people require aren't necessarily in the medical model. And that concerns me. It would result in the elimination of the minimum benefit, for example. Does that concern you?
I think there's a lot of things about the parity bill which concerns everyone. I don't think that it's a pure bill. It's certainly nothing that I would, if I were to write the bill, that I would really find acceptable. I think it is the medical model. I think you're right. In other states that it's passed, it's not that even that it's passed, it's trying to implement it. So there's a myriad of problems with the parity bill. However, I think that it's just, as I said, it's just sort of a first stab at trying to, you know, have equal coverage for people with mental illness.
What about the confidentiality aspects of it as well?
That's troublesome.
Very troublesome.
Very troublesome.
Because I'm going to have to really convince somebody at the end of a telephone that the services I'm requesting are medically necessary. So I'm going to have to be fairly convincing.
Right, and I think medical necessity, that term is used differently by different people to fit their own needs, and it's not always in the best interest of the patient. I find medical necessity, something that's sort of used by, people to fulfill their own needs.
So, I had an opportunity to talk with your husband before today's show about the importance of work. Now, psychosocial rehabilitation may not be considered medically necessary, even though it may be life-saving.
Right.
So how would the Alliance propose blending the different approaches?
I think that it has to be a total package. It just can't be one or the other. I think it has to be, people need to work. They need to feel valued. They need to have a purpose in life, just like you and I do. They need to be able to go out and feel that they have earned a wage for a day's work. We absolutely must have the total package. It can't be either or. It can't be either we get the services, the medical services, or we get the psychosocial services. We need it all.
But getting it all is always where it seems to break down. Mr. M, for example, he comes regularly, he's med compliant, but he can't quite muster the courage to go back to work. He actually has a job, and they're very nice. They're waiting for him, but he can't quite get back there. A lot of the work I might want to do with Mr. M wouldn't necessarily be considered medically necessary because he's med compliant. He's taking good doses of the atypical antipsychotics and actually looks well and presents well, but can't bring himself to get up and go to work. How do we figure out the total package and then get the legislature to appropriately fund it?
That's a really good question. I think one of the things is that we need to educate the legislators in terms of what is necessary in order for a person to feel well. And I think we have some legislators who are terrific. We have other legislators who just are not that interested. I feel with the work program, people need to have great support. Some people need to go to work. They need to have someone on site, certainly someone who is available at a moment's notice by telephone. They need a buddy system. I mean, a warm line. There are all sorts of, I think, supports that our folks need because of their illness. And as I said, this is a lifelong illness for many people, ups and downs and all over the place.
Well, after the break, which is now, maybe we could talk a little bit about, in the context of those supports, outpatient commitment, and why it's such a sticky wicket when it comes to Massachusetts. So we'll take a break at this point.
It is more than a trial by fire. It is a rite of passage, a challenge to join the elite. And if you succeed, if you can master your fear, outsmart your enemy, and never yield even to yourself, you will be changed forever. The few, the proud, the Marines.
Imagine yourself serving in today's Peace Corps.
I wanted adventure. I wanted to go out, learn about a new culture, learn a new language, and bring it back to the United States.
You know for sure for 2 years it's going to be like nothing you've ever experienced.
I joined the Peace Corps because I think Peace Corps as a development organization is one of the best in the world.
My dream of becoming a physician, if anything, has become enhanced. The best part of my experience here, I think, as a volunteer is that I found a second family.
I think one of the best things you can do with your time, it's a great program where you can come and help people out excited about it.
There's a role for you in Peace Corps. It never really feels like work. You love what you're going through. You're helping people, you're working in the community, and people really appreciate you so much for every little bitty thing that you do.
It's fun.
Make a difference. Join the Peace Corps. It's the toughest job you'll ever love.
Well, let's talk a little bit about outpatient commitment, because that's a priority for the Alliance. There are a lot of good people in Massachusetts who are against it. So whether you and I will have an opportunity to see it enacted as far as the legislature is concerned, good question. What are your thoughts about it? Why do we need it? Where would it help us?
I think it would help us with the non-compliance issue, and I think, I feel that since it is a brain disease, not unlike diabetes, where you need insulin, heart disease, where you need medication, people need medication in order to stabilize and in order to carry on with their life to the fullest extent possible. And however, many people, I feel, because some of them who have been in the system for a long time, who have subjected themselves to some of the symptoms of the side effects of the older medications, they are very reluctant to hook into some of the new atypicals, which in my other son's case, I have another son who has got schizophrenia, has been absolutely fantastic. And it's not for everyone. No medication is for everyone. One size does not fit all. However, I really, because of my own personal experience, I would like to see other people reach their highest level of functioning. And I think that since it is a brain disease, we must do this with medication.
But is it not my right to say no?
It certainly is your right to say no, and I think I think today you can say no, and even if there was a bill, you could say no. I really feel that the bill would not, my perception of what a bill that I would like would be that it wouldn't be coercive, that there would be different avenues of explaining to the clients that this is in their best interest, and maybe educating them more. I think if excellent psychiatrists like you educate your patients. When I hear that some of our family members go in and they have 7 minutes with their psychiatrist, and there is just they don't even know what medications they're taking, the clients many times. And I think I just foresee it as something that would be educationally as well as psychiatrically feasible.
So I'm not sure how you see it working. I mean, if it's not coercive, I mean, because the ones who come in and are willing to negotiate with me, they might finally say no, they're not interested in the services that I have to provide, and then of course I can ask them why they want to continue suffering the way they do. A lot of people won't come in. So I don't know how the bill would work unless it also allowed for some coercion when you had somebody who was so clearly ill on the one hand and so resistant. Because, you know, we're talking about the numbers are not necessarily statistically that high, but the total number of people is very important, you know, who are failing in community systems. Now, and some of that may be reflecting their illness and their resistance to treatment. The way I feel about the involuntary commitment bill is I have sort of researched it through the other states in which it has become law, and from my indicators, which from my national organization, is that it is working well, and that there is a sense of that the clients understand
once one of them feels better, then it sort of touches other people's lives.
The ripple effect.
And the ripple effect.
But are you sort of suggesting that it really would be an extension of inpatient commitment into the outpatient? It wouldn't be something one could start up in an outpatient setting?
I think that it's doable to start up in an outpatient setting. The only problem with that is that there needs, again, to be, if you start medication in an outpatient setting, there needs to be tremendous safeguards in place.
Sure.
So that the oversight mechanism would be, so strong, so that if people did start decompensating or they had some side effects, then you would be there to hold their hand and say, all right, this hasn't worked, so we will do something, differently. And that I think that people need to understand that there was a lot of different medications that are available to them, and that there is hope that they can feel better than they do today.
But many people are afraid to get their hopes up, so they'll say categorically no. They'll think I'm selling them some kind of a used car.
Right.
Again, I don't know how to avoid coercion when you finally get yourself into a situation where someone is so clearly ill, so clearly suffering, and yet so clearly resistant. I guess I keep asking the same question.
I think that's I know you do, and I think that's the challenge, which I really don't have an answer for. I think it's a constant struggle of non-compliance for people, and it's as president of the Alliance, we get many, many phone calls each week.
What to
do from family members with people who, it's one of our biggest, challenges with people who are non-compliant. Some of the non-compliance is just because people forget to take their medications. Again, if they're in an inappropriate setting, they just, they just don't remember to take them, and it's not because they don't want to, it's just that again, the supports aren't in place so that they, can move along with it and know what they, how much they should take, and some of them just throw it away. I mean, I think we need to have some kind of a system which makes sense for both the clients and for the physicians. And I'm not sure what the answer is, I guess is what I'm saying, because I really, I've seen some horrible things happen to some of our members' children because of non-compliance. Some really very, very negative behavior, which has ended, they've ended up in jail for long periods of time in which they don't receive the medication that they need.
Of course, we do have the Rogers mechanism, but drawing from that experience, where we can get court permission to medicate people against their will, outpatient as well as inpatient, we have some very serious problems enforcing it. I remember one older woman who had a Rogers, who was pleasantly psychotic, but also adamant that she would not under any conditions take medication. Now, I'm not in a hospital, I'm in a community-based mental health clinic. How do I force her? Well, I did, and I only had to do it once. And fortunately, I was big enough and she was small enough that I could take her gently by the hands while a female nurse administered an injection. And from then on, we're now talking about 5 or 6 years later, she has flourished. But I can tell you, for me, that was an existential moment because I wasn't really sure what I should do properly to force her to take the medication, even though the court had said I could. So the same with outpatient commitment. What are your thoughts about patients who are committed for outpatient services who still don't show up?
It's
That's
a real
tough one.
challenge. It really is. And I don't think there's any easy answers to that. I'm very interested in this particular bill because of that. What, are you going to go out and find them, bring them, and force them to take medication?
Well, maybe we need to, although that gets to another question I want to ask you that I think has to do with privatization. I would love to be able to go out and find people who aren't coming. One of our problems is to keep track of the people who don't show up. In other words, it's easy to keep track of the people who are showing up. but we lose track of people who don't keep their appointments, particularly if we're seeing a lot of patients, which we do in South Boston. How do you figure out a system that enables clinicians to go out and not case finding, that's another problem, but actually locate people who aren't keeping their appointments?
That is a whole new challenge in itself. The other day we were talking about the partnership, the Massachusetts Behavioral Health Partnership, which is the Medicaid managed care organization. What would make sense for performance standards for next year? And one of the things which I proposed was that we track people for a period of a year, and they just don't fall through the cracks, because I think with our system, we have a very, very fragmented system. We have a three-tiered system. We have the Medicaid, which pays the bills, that's the funding mechanism. We have the Department of Mental Health, which takes care of the chronic care services, and then we have the partnership, which takes care of the emergency and acute care services. And this does not make sense to have three different entities, aside from the cost, because you have a tremendous cost incentive to, for instance, from the partnership, because they get paid on meeting these performance standards. And plus their administration costs are high. If we had one...
$15 million a year.
Right. If we had one specific agency and we could save all that money and just sort of put it all on the table and figure out how can we provide the best services for each individual client. It just, to me, makes so much common sense.
It's too commonsensical, because it's easily accomplished, but you have to take back all the money and start over. And there have been recently some studies, I'm sure you've read them, about how, in fact, if you analyze the monies available, that there really are sufficient monies in the system, but that you really have to ask all these insurance companies and all the private vendors to go out of business and develop a single payer system, and I guess rebuild DMH into a creditable service delivery system that coordinates care and provides, total care.
Of course, I think that's my dream, that we would have that single payer system, because I think that we could serve the people in a much more proactive way instead of reacting as things really, start deteriorating. We could just, that's my dream. I don't think I'll ever see it in my lifetime, because they say that privatization is here to stay, and
we have to take a break, but maybe in the last segment after the break we can do a little dreaming, and you can tell us a little bit about the challenges ahead, particularly as we approach the new millennium. So we'll come back to these questions.
As America has changed, Social Security has changed. A foundation of monthly income for retired workers was created in 1935. Then changes were made to provide for widows and widowers, and for disabled workers and their families. Later still, changes were made to ensure that benefit payments would always keep up with inflation. Now Social Security will need to change to provide for the retirement of 76 million baby boomers early in the next century. It's a big job, and it needs to be done right, so that Social Security will continue to help support not only the baby boomers, but their children and grandchildren as well. You can help draft the blueprints for the coming change by learning about the issues involved and our options. For more information, call 1-800-772-1213 and ask for the booklet, The Future of Social Security.
If you give me a fish...
Give a man a fish.
If you give someone a fish...
You feed them for a day. A day.
One day.
If you give someone a fish, you feed them for a day. But if you teach a man to fish...
Teach me to fish.
Teach someone to fish.
and you feed me for a lifetime.
A lifetime.
My whole life.
If you teach someone to fish, you feed them for a lifetime.
Give me a fish, and you'll feed me for a day. Teach me to fish, and you'll feed me for a lifetime.
Through Volunteers of America, you can help change lives in your community. Find out what you can do. Give us a call.
Well, you made a reference to the single-payer system, and I think that at least most of the reasonable people I know feel that in many ways that is eventually going to be the solution. Let's talk a little bit about what keeps us from that. And specifically, I'd like to ask you some questions about your experience with privatization and the pros and cons. Again, I guess in the context of community systems that fail and the needs of the long-term mentally ill.
Well, I think privatization has failed, as I think many people would agree with me. I feel that, and many of my members who I'm very close with feel strongly in that direction. We have one of our people on our board lost a son to suicide less than a year ago, and she felt that the community system let him down by transitioning him inappropriately from, one particular area to another too quickly. I think if we had a system that was just a single-payer system, we could take and we could figure out very appropriately how much we wanted to put into the community supports area, how much it was necessary for this area, how much was, for the acute care area. I think with the advent of new medications, and maybe people don't need that much time in the hospital anymore. Maybe what they need is, but when they come out of the hospital, maybe they need very, very strong linkages. We don't get this with privatization because people fall through the cracks. As they go from one system to another, they fall through the cracks, and then there are new regulations which have come out of the Department of Mental Health, which makes it more difficult to become a client. If you're not a client, you get no support services. There's just a number of different reasons why we really need to be on the same page, and as advocates, and I will look out to this audience and say that everyone that is watching this knows someone who is mentally ill, because we have such a propensity of people who are mentally ill in the Commonwealth of Massachusetts and in the nation. And they are our families, our neighbors, our friends. So if 1 in every 4 people have some form of mental illness, we know somebody. And I think what I challenge people to get together and try and make a difference by engaging in something that makes sense in terms of a community support and service delivery system.
But we've gone away from that really in the last 25 years. I mean, I can quickly give you the name of 3 or 4 patients who spring to mind who are getting services from the New England Medical Center, Bay Cove Human Services, DMH, and Vinfen. Same one patient getting services from at least 4 different vendor corporations. There are 1,200 vendor corporations in Massachusetts.
See, and many of our clients, consumers, do not know where they're getting their services from. People, it's been my experience that people know that they have a mass health card if they're on Medicaid. They don't know what services they even can get from that mass health card. So the education, your particular people that you're talking about, they probably don't even know what services they get from one, or what VinFen provides, what you do, but what New England Medical Center. They just know that they see many different people during a period of a month. And does that make sense? And I think the human connection is very, very important. We need to have one person especially someone who is ill, that they can really depend on, that they can really strategize with in terms of how they can most effectively live their lives with the highest quality possible, and who is compassionate. We don't need someone who is, who you just jump in, and as I say, if 7 minutes, and this is my experience, that people say it's just like the revolving door, and it just doesn't make sense because health-wise, it's just not good. And I challenge people who are watching who have physical problems. They wouldn't like to be served by 4 different masters neither.
But that is really very typical, and it's very interesting that the people that are likely to be the consistent advocates probably stay in their jobs for, I don't know the exact average, but I would guess it's probably not much more than 2 years at a time. So the turnover, again, because the vendorship system has resulted in wages being lowered and fringe benefit packages not necessarily being either available or equal, the turnover is horrendous. So even when there is a human connection, like right now in the South Boston community, staff that work in a community rehabilitation program are all resigning because the contract was just given to a different vendor who wants to hire new people. Clinically, it's mind-boggling.
See, I think that there's only the resolution to this whole problem is adequate legislation to prevent this from happening, because it's going to keep happening over and over again unless it's absolutely against the law and they cannot do this. And it has to make sense that as I said, as human beings, we all deserve, as we go through this life of ours, dignity and respect. And I think that when you have people that are, and it happened to my son, he was taken away from a person who he really cared for about as his social worker who was in charge of this home. This was the beginning of his deterioration, I felt, and we still see Karen, but if he just could not understand why these supports were taken away from him when he was, at that time, feeling so secure, so up, and he was making such good progress. Now, it does not make sense emotionally, psychologically, even it's not cost effective. So I think that's another thing that maybe our legislators should, think about.
So the Alliance has the problem in clear focus. Do you think the Department of Mental Health does?
I certainly think they do. I think that the governor has a certain stature that and mandates, and I think that when you work under the governor, you sort of have to either go with his administrative, agendas, or it doesn't work for you, and I think that's.
So you're being a little vague here. Are you suggesting that his commitment to some of these initiatives is not as strong as
I don't think
Dukakis's was, for example?
Well, no, I don't think that. I think many people who will watch this understand. Certainly, my friends, even who aren't have children in the mental health system, understand that our present governor does not really have any sort of a commitment to the mentally ill. I mean, I think he has a lot of things that he's doing right now that I object to because the stadium bill, etc. And I know I'm down in this territory, but when I see so much emphasis being placed on that when lives are on the line, it really it angers me tremendously.
So are you angry enough to maybe share with us what your sort of mission is as we approach the new millennium, and what you think the Alliance can do to be part of the solution?
Well, I think we need to form very strong coalitions in terms of with our affiliates. I think we have to come out in force. We have to make ourselves heard in a much louder and clearer voice. We need to I think, revisit our mission, really, and try and make things work in a much more acceptable way. I think we've had our ups and downs, but I think now we're on the upward turn, and I think that we really need to go forward united with our, as I said, with a circle formed around our mentally ill people, and that includes not only our family, not only NAMI people, that includes the psychiatrists who do care, and there's so many of you folks out there. There are people in the mental health system who are truly wonderful, and I think within the constraints of their job, they cannot fully do the things that they want to do for their people, and that is why there's so much burnout, and that's why people are leaving, and so frustrating. But we hope to really, I think mainly our mission is join together and make a difference, because I keep telling my people there are power in numbers, and together we can make a difference.
So in the last couple of minutes, sort of your wish list for the new year, for the new millennium, if you had an opportunity to have some of your wishes come true, what would you hope for?
Well, I would wish for certainly a single-payer system, which to me makes sense. I would wish that our family members were afforded the same dignity that the rest of us expect, that they would be provided the same services, and they would be listened to. I think the consumer movement is very interesting in that I think that it needs to expand. I think we have some very good consumers who are very verbal, but I think that we need to listen to the consumers, respect them. We have consumers who work in our office who our treasurers, we call them, and I think everybody needs to, we all need to work together. I think that's one of the things, not just NAMI people, not just psychiatrists. I think we all need to join, and we need to do things that doesn't make sense, that makes sense not only financially, because but makes sense from the heart, in the heart. And that's, I think, what I would like to see in the new millennium is that we are able to move forward with that.
Well, I'm delighted to have this opportunity to chat with you about some of these issues.
It's very nice. Thank you for inviting me.
Well, my pleasure, and I wish you well in your reign as the president during these very tricky times. I just hope that we do have an opportunity to sort of eliminate some of the unnecessary overhead and some of the discontinuities, and get on with a system that is a little more inviting to those with persistent and chronic mental illness. So.
Well, that is my wish also, and it has been a real pleasure being here. And as I said, I worked in South Boston as a public health nurse many years ago for the city of Boston. So, and I do think we need to. I think we need to all clone ourselves so that we have many other. Minutes, hours, days to really pay attention to our family members and consumers.
Thank you, and thank your husband for helping you be here today.
Okay.
And on behalf of Mind Over Matter, I want to thank you again and thank the Alliance for making this show possible and for your being here. Thank you.
Thank you, Dr.